New Ballard score. New Ballard score is a clinical scoring system that helps us to assess the gestational age of the newborn based on neuromuscular and physical maturity criteria. Now, what are the uses? The uses of it is used in the estimation of the gestational age when it is a case of unbooked pregnancies, where the last menstrual period is unknown, sick neonates, or in case of adoption or abandoned babies. Assessment of prematurity or post-maturity can also be done on the basis of the Ballard score. The components, there as I said, there are two components: neuromuscular and physical maturity. There are six in each. First, talking about the neuromuscular maturity, here the first is the posture. So a flexion posture is seen in case of term infant. When in preterm infants there is going to be extension. Then square window. Square window is the angle between the palm and the forearm. As the age increases, the angle is going to decrease. Then next is arm recoil. So arm recoil, upon the stretching of the arm, the speed and the strength of flexion is measured. So the arm recoil, it talks about a tone, and it is more in case of term infants. Then another in the upper limb is going to be the scarf sign, is the ability to move the elbow across the chest. So it is present in case of preterm infants and it is absent in case of term infants. Then popliteal angle. Popliteal angle is the resistance to knee extension. So it is, so the popliteal angle is more in case of preterm infants and it is less in term infants. Heel to ear test, it checks the flexibility. It is more in preterm infants. That is, the heel to ear test is possible in preterm infants. It is not possible in case of term infant. Then the physical maturity. Physical maturity, again there are six signs. The skin. In the skin we talk about the texture, transparency, and cracking or peeling of the skin, which is present in post-term infants. Lanugo are the soft, thin hairs that appear and they decrease near the term. Then the plantar creases. Then breast tissue, that is the areola and the breast bud size, it increases with the age. Then eyes and ears, we talk about the ear cartilage firmness and the pinna recoil. Then the genitalia, in case of males, the testicular descent and the scrotal rugae is assessed, while in females the labia majora progressively covering the labia minora is going to be assessed. Now each parameter of this neuromuscular and physical maturity, it carries a score of -1 to +5. -1 means extremely immature, while +5 means mature. So the total score is the sum of the neuromuscular and physical scores, and it corresponds to the gestational age of 20 to 44 weeks. The interpretation, if it is less than 37 weeks, we call it as a preterm. If it is 37 to 42 weeks, we call it as a term. And if it is more than 42 weeks, we call it as the post-term infant. The timing of assessment, it should be ideally done within 12 to 24 hours of birth, and it can be done up to 4 days after the birth. The accuracy is about ±1 week. Then advantages, it is applicable in case of extremely premature infants as well. It is more accurate in the old Ballard score, and it is useful when the obstetric rating is unavailable. Limitations, this particular score is affected in birth asphyxia, neuromuscular disorders, or in case of sedation or illness of the baby. The next is unconjugated hyperbilirubinemia in neonate. So unconjugated hyperbilirubinemia is a very common neonatal condition that is characterized by elevated levels of unconjugated bilirubin, and this unconjugated bilirubin, it can easily cross the blood-brain barrier, and because of which it poses a risk for kernicterus, that is bilirubin encephalopathy. So pathophysiology is that it results from an imbalance between the bilirubin production and elimination. Neonates, they have a higher RBC mass, they have immature hepatic enzymes, and at the same time shorter RBC span, because of which the hemolysis is more, but the hepatic enzymes are immature to remove the bilirubin, and impaired bilirubin conjugation is present. Then the causative factors are the increased bilirubin load, as in case of hemolysis. If it's a case of isoimmunization, that is erythroblastosis fetalis, Rh isoimmunization, or ABO isoimmunization, it presents as early, but it presents as mild to moderate jaundice, while in Rh isoimmunization it presents as severe jaundice with features of hydrops fetalis. Then enzyme deficiencies like G6PD deficiency or pyruvate kinase deficiency. Then membrane defects like hereditary spherocytosis. Increased RBC mass, that is polycythemia, is seen in postpartum pregnancy, delayed cord clamping. Extravascular blood, that is extravasation of the blood, is seen in case of cephalometoma that predisposes to jaundice. Then decreased clearance is seen in case of physiological jaundice. So 60% of the neonates suffer from jaundice, out of which 80% of them suffer from physiological jaundice, and this is because of the immaturity of the hepatic enzymes. The breastfeeding jaundice, it is caused because of inadequate intake. It is also called as suboptimal intake hyperbilirubinemia. Breast milk jaundice is because of the factor in the breast milk that is called as beta glucuronidase. It is a diagnosis of exclusion. Generally, if the jaundice uh, persists for more than 3 weeks, then we rule it out as breast milk jaundice. In both breastfeeding and breast milk jaundice, the breastfeeding should be continued. Then other causes can be sepsis, but sepsis presents with other features like hypothermia, hypoglycemia, feeding difficulties, apnea, hypothyroidism, and Crigler-Najjar syndrome. Crigler-Najjar syndrome is the UDP-GT, UDP galactose transferase enzyme deficiency. So Crigler-Najjar type 1 or type 2. Type 2, it can be managed by phenobarbital. Crigler-Najjar type 1 cannot be managed by drugs. Then the clinical features will be jaundice, that is yellowish discoloration, the sclera and the mucous membranes. Apart from that, the skin. If it happens after 24 hours of life, it's a physiological jaundice within 24 hours of life involving palms and soles, and if the total serum bilirubin rises for more than 5 milligrams per day, then that's a pathological jaundice. Always the jaundice, it progresses in cephalocaudal direction. The baby is usually well appearing unless bilirubin is extremely high. Investigations for that, we need to go for visual assessment by Kramer's zone, transcutaneous bilirubinometry, or the best investigation is total serum bilirubin levels by lab assessment. Then the next is the management. So the management goal is just to prevent the kernicterus. Now here, first we do is when the neonate comes to the jaundice, we assess the serum bilirubin levels, plot it on a Bhutanese nomogram based on the age in hours. If it comes under high risk zone, then we start immediate phototherapy. If it's still the bilirubin levels they continue to rise, then in that case exchange transfusion is done. If they fall, then continue with the phototherapy until the level declines safely. If it falls in the intermediate to high zone, then also we have to go for phototherapy and at the same time supportive care by frequent breastfeeding and continuous monitoring of bilirubin. If it falls from low to intermediate zone, then in that particular case, you have to observe the baby and repeat the test every 4 to 12 hours. And if it goes and if the serum bilirubin level increases, then you have to consider phototherapy. So this is the management of unconjugated hyperbilirubinemia. Now the next question in Balani is neonatal jaundice, physiological jaundice and its management. So physiological jaundice is a most common cause of readmission and morbidity in case of a newborn in the first week. 60% of the neonates they suffer from jaundice, out of which 80% of them they suffer from physiological jaundice. The physiological jaundice, it is characterized by onset after 24 hours of life. It does not involve the palms and soles, and the rise in the serum bilirubin levels is less, while it is only has unconjugated hyperbilirubinemia, and because of which there is a risk of kernicterus that happens. Then the peak, it peaks at around 3 to 5 days of age in case of term infants, in preterm about 5 to 7 weeks. Then it remains for up to 1 to 2 weeks in case of term infants and resolves by 3 weeks in case of preterm infants. Bilirubin levels usually do not exceed 15 milligrams per day in term infants. The clinical condition is the infant is otherwise well, feeding adequately, and has no signs of illness. Then the management, phototherapy. So phototherapy remains to be the main stay of treatment. The phototherapy, it consists of three important mechanisms, that is photoisomerization, structural isomerization, and photooxidation, out of which the structural isomerization is the most important. This will convert the unconjugated bilirubin into lumirubin, and this water soluble lumirubin can be passed out from the body in the form of urine. Now, it is done with the help of LED lights, and a wavelength of 460 to 490 nanometer is maintained. The distance from the baby should be 30 to 45 centimeters, and the genitals and the eyes of the baby should be covered. The disadvantage of this is that it can lead to Brown's baby syndrome and diarrhea. Then the next is exchange transfusion. Exchange transfusion is done when the phototherapy fails. So exchange transfusion is used to prevent the kernicterus in case of very high levels of bilirubin. The mechanism is that it directly removes the serum bilirubin levels and the maternal antibodies from the bloodstream and donates it with a donor blood. Double volume exchange transfusion about 160 to 180 ml per kg is done in case of erythroblastosis fetalis. Indication when it goes into the high risk zone on the Bhutanese nomogram. Then supportive care that is given is that if breastfeeding should be continued and IV fluid should be given to the baby if the baby goes is dehydrated. In case of term infants, we can have this criteria, that is if the age is 24 to 48 hours, 48 to 72 hours, and more than 72 hours, then the phototherapy cutoff is 15, 18, and 20, and exchange transfusion cutoff is 20, 25, and 25. In case of preterm infants, the phototherapy cutoff is 1% of the body weight in case of in grams, while the blood transfusion cutoff is plus 5% of the phototherapy cutoff. The next question is severe jaundice in a 28-year-old homeborn newborn. What are the clinical features, differential diagnosis, and the management? So, jaundice presenting in 28-year-old home delivered newborn is mostly a case of pathological jaundice, as if the serum bilirubin levels would have been started to increase within 24 hours. So, that is called as the pathological jaundice. The treatment will most likely benefit than harm the patient. Now, the causative factors for this will be the hemolytic diseases like the erythroblastoma fetalis and RH isoimmunization. In ABO isoimmunization happens when the mother's blood group is O positive and when the child's blood group is A positive. Then other minor blood group incompatibilities can also be seen. Enzyme deficiencies as in G6PD deficiency and pyruvate kinase deficiency, membrane defects as in case of hereditary spherocytosis, intrauterine infections or sepsis also leads to jaundice. Similarly, unconjugated jaundice can also be seen in case of Crigler-Najjar syndrome, where there is UDP-GT enzyme deficiencies. Then conjugated jaundice, conjugated hyperbilirubinemia, it is seen in cases of obstruction. So that can be either extrahepatic obstruction or intrahepatic obstruction. Extrahepatic obstruction is seen in case of extrahepatic biliary atresia, which is the most common cause of liver transplant in neonate. While the intrahepatic obstruction, it is seen in case of Caroli syndrome or Alagille syndrome. The non-obstructive causes will be the viral hepatitis, galactosemia, fructose disorders, or alpha-1 antitrypsin deficiency. Then the clinical features. The presenting complaint will be the yellowish discoloration of the skin, and it will be cephalocaudal in presentation. Dermal staining can be seen by visual assessment of the Kramer zone. If it involves the head and the neck region, then the serum bilirubin levels will be most likely between 5 to 7. Then if it involves the chest and the trunk region, then 7 to 9. If it involves the lower abdomen and the thigh, it will be 9 to 11. 11 to 13 in case of legs and the forearms, and if it involves the palms and soles, then it is 13 to 15 or more than 15. That shows the danger sign. Then associated signs is that the baby may show signs of lethargy, poor feeding, or high-pitched cry. Then there can be signs of anemia and hepatomegaly as well. Differential diagnosis can be these different conditions like RH isoimmunization can be present, ABO isoimmunization, G6PD deficiency, hereditary spherocytosis. Non-hemolytic causes can be physiological jaundice, but however it appears after 24 hours and generally not severe in nature, so it is ruled out. Intrauterine infection, sepsis, and it is associated with other signs like this temperature instability, there is hypothermia, feeding intolerance, hypoglycemia, apnea. So these can be the differential diagnosis. The management of this uh, baby will be immediate total serum bilirubin assessment. First line investigation will be the blood group for ABO isoimmunization and RH isoimmunization. Direct Coombs test can be done. Peripheral smear to look for hemolytic anemia, that is spherocytes and all. Then hematocrit doses for the anemia. Similarly, the second line investigation can be G6PD levels, sepsis screen if sepsis is thought of. Then the therapeutic interventions will be the phototherapy. Phototherapy remains to be the mainstay of the treatment, and an exchange transfusion can also be done. Supportive care in the form of adequate hydration and encourage and support the breastfeeding. The therapeutic interventions have been covered in the previous video. The note on connectedness, a special note on connectedness refers to the chronic and permanent neurological sequelae that comes from bilirubin toxicity, leading to bilirubin encephalopathy. So if it's an acute case, it is called as ABE, that is acute bilirubin encephalopathy, and chronic case is called as chronic bilirubin encephalopathy. Acute bilirubin encephalopathy, it presents as hypotonia followed by hypertonia with a shrill cry or high-pitched cry. Here, opisthotonus and retropolis are seen along with fevers and seizures. In case of chronic kernicterus, the features are chorioathetoid cerebral palsy, where involuntary ringing movements or writhing movements of the hands and legs happen. Then high-frequency hearing loss, dental enamel dysplasia, that is greenish to discoloration of the tooth, and paralysis of the upward gaze. And cardiac arrest is more of a preventable condition, and this happens because of unconjugated hyperbilirubinemia, where unconjugated bilirubin is going to cross the brain-brain barrier, and this blood, when it crosses the blood-brain barrier, it's going to affect the basal ganglia. Sepsis. Sepsis is characterized by bacterial inflammation with or without the presence of pneumonia and meningitis. Then the sepsis is divided into two categories: early onset sepsis and late onset sepsis. Early onset sepsis is within 72 hours, and late onset sepsis is sepsis after 72 hours. The causative factors for early onset sepsis are divided into maternal causes, intrauterine infection or inflammation, and the fetal associated factors. The maternal associated factors, they are going to be foul smelling liquor that is seen in case of chorioamnionitis, or it is preterm labor or premature rupture of membranes. Then the fetal associated factors, they are going to be the low birth weight babies, prematurity, or perinatal asphyxia. In the late onset, it is divided as nosocomial factors and the community acquired causes. So the nosocomial causes are NICU admission, repeated invasive procedures, multiple needle sites for injection, or repeated handling of the baby, mechanical ventilation or stock solutions. Then the community related factors are going to be poor hygiene, poor cord care, pre-lactal feeds, or lack of breastfeeding or bottled feeding. So these can be the causes of late onset sepsis. Early onset sepsis is associated with pneumonia, while the late onset sepsis is generally associated with meningitis. The most important step in the prevention of sepsis in hospital settings or community settings is going to be hand washing, to follow all the proper 6 steps that are present in hand washing. Then the most common causative organism in India is Klebsiella, followed by Acinetobacter. In the hospital settings worldwide, it is E. coli, while overall it's the group B Streptococcus. The clinical features of sepsis is the earliest feature, that is poor feeding, lethargy. Then there will be hypoglycemia, lactic acidosis, hyperbilirubinemia, apneic spills. There can be the features of DIC, necrotizing enterocolitis, seizures, and other features can be present. The diagnosis, the confirmatory diagnosis is done by blood culture, but it takes 2 to 3 days for the blood culture to arrive. Till that, the sepsis screen is done. It consists of 4 criteria: AMC. So A stands for the absolute neutrophil count. If it is less than 1800, then it is suggestive of it. Then IT ratio, that is immature to total neutrophil ratio, it is more than 0.2. Then micro ESR, if it is more than 15 millimeter per hour, and the CRP levels are more than 1 milligrams per dl. If any 2 out of these 4 factors are present, then that means it's a high possibility of sepsis. New marker is procalcitonin. The negative predictive value of sepsis screen is 100%, but the positive predictive value is 25%. Additional investigations of blood glucose levels, chest X-ray, lumbar puncture for meningitis, and arterial blood gas analysis. Management is supportive management, that is IV fluids are given, maintain the euthermia, euglycemia, oxygen to the baby. So the specific management is giving empirical antibiotics that includes ampicillin, gentamicin, and metronidazole. If the sepsis screen is negative and blood culture, lumbar puncture, meningitis is not suggestive of meningitis, then in that particular case, the antibiotic cover should be given for at least 3 days. If sepsis screen is positive, then it should be given for 1 week. If it's sepsis screen and blood culture is positive, then it should be given for 2 weeks. And if all the 3 are positive, then the antibiotic cover should be given for 3 weeks. Neonatal hypoglycemia. Neonatal hypoglycemia is defined when the blood glucose levels are less than 45 milligrams per dl. The high risk for neonatal hypoglycemia is short for gestational age babies, intrauterine growth restriction or preterm babies. Similarly, large for dead babies or infant or diabetic mother, hypothermia and sepsis. These are all the risk factors for neonatal hypoglycemia. In case of neonatal hypoglycemia, serial blood glucose monitoring should be done at 2, 6, 12, 24, 48, and 72 hours. The earliest clinical feature is the jitteriness, followed by pallor, lethargy, poor feeding, apnea, and cyanosis. The management of neonatal hypoglycemia, if the child is symptomatic in nature, then IV dextrose 2 ml per kg is given stat. Then, if it is still not improving, then glucose infusion rate at 6 mg per kg per minute should be given. Maximum infusion that can be allowed is 12 mg per kg per minute. Monitor the blood glucose levels. If more than or equal to 2 consecutive values, they come to be more than 50, then in that particular case, taper the dose at 2 mg per kg per minute and discontinue it. If the child is asymptomatic, then monitor the blood glucose levels. If they are less than 20, then start with the glucose infusion. And further, if the blood glucose levels are between 20 to 45 and the child is asymptomatic, then oral feeds or breastfeeding is given and recheck after 30 minutes to 1 hour. If it decreases further, then glucose infusion is given. But if the blood glucose rise more than 45 milligrams per day, then that case uh, advice for frequent breastfeeding and early monitoring. Then persistent hypoglycemia. Persistent hypoglycemia means when the glucose infusion rate required is more than 12 mg per kg per minute, and it persists for more than 7 days. Then that's considered to be persistent hypoglycemia. The causes for persistent hypoglycemia are congenital hypoparathyroidism, then hyperinsulinemia, that is called as acidoblastosis, wherein beta cell hyperplasia is there. Then PHHI, that is persistent hyperinsulinemic hypoglycemia of infancy, hereditary fructose intolerance, galactosemia, and glycogen disorder, that is Von-Kerkes disease. The management medical therapy consists of diazoxide, octreotide, glucagon, and hydrocortisone, out of which the glucagon and the diazoxide, they are contraindicated in case of neonates. Then infant or diabetic mother, it follows a hypothesis that is called as Peterson's hypothesis. So in Peterson's hypothesis, when the maternal glucose it enters into the pancreas, into the fetus, the fetal pancreas, they are normal, and because of which they are going to respond to this increased glucose by increased production of insulin, and because of which all this glucose is stored at fats around the shoulders, around the hips of the baby, and because of which the baby will appear large for gestational age. The insulin acts as a growth factor in this, and there will be macrosomia, prominent shoulders, difficult or prolonged labor, high chances of perinatal asphyxia, trauma, neonatal jaundice, and extramedullary hematopoiesis. When there is extramedullary hematopoiesis, the viscosity of the blood increases, increasing the chances of thromboembolism. Then, the most common congenital anomaly is related to the cardiovascular system greater than CNS system. The most common in cardiovascular system is the ventricular septal defect, while the most common in nervous system is going to be the neural tube defect, that is spina bifida. The most specific in cardiovascular system is transposition of the great arteries, while the most specific in case of central nervous system is going to be the sacral agenesis or the caudal regression syndrome. So these are the common and the specific congenital defects seen in overt diabetes mellitus. So in an infant of what mother who has a overt diabetes mellitus and uncontrolled hyperglycemia. The most common cardiac finding is HOCM, hypertrophic obstructive cardiomyopathy. Apart from that, other metabolic abnormalities are hypoglycemia, hypocalcemia. Hypocalcemia is less than 8 milligrams per dl of calcium levels. Hypomagnesemia less than 1.5 milligrams per dl. And hypoparathyroidism as well. So these are the features of neonatal hypoglycemia. Hypothermia. So the best site to measure the temperature in the case of a newborn is the axillary temperature. The normal temperature of a newborn is between 36.5 to 37.5 degrees Celsius. It is considered to be a cold stress if it is from 36 to 36.5 degrees Celsius. Moderate hypothermia is from 32 to 36 degrees Celsius, and it is less than 32 degrees Celsius, and that is considered to be severe hypothermia. The sources of heat loss in babies are going to be conduction, convection, radiation, and evaporation, out of which the radiation is the most common and most prominent. Sources of heat production are the brown fat that is deposited at the nape of the neck or in the perirenal region or interscapular region. So the uncoupling leading to oxidation of this fat leads to heat production. Cutaneous and pulmonary vasoconstriction and flex posture. Then hypothermia is more common in infants because they have a greater surface area, less subcutaneous fat, thin permeable membrane. There is no shivering mechanism, and they are more vulnerable to this. Hypothermia, it will lead to catecholamine release. Because of catecholamine release, it will lead to uncoupling of the beta oxidation of the fats, and that will lead to hyperbilirubinemia. Then similarly, it leads to increased metabolic rate and heart rate. Because of increased metabolic rate, that will lead to hypoglycemia, while increased heart rate is also seen. Then the next is it will lead to pulmonary and peripheral skin vasoconstriction, and that will lead to anaerobic metabolism, and hypoxemia, metabolic acidosis develops. So these are the other features that are seen along with hypothermia. It is considered to be a cold stress when the abdomen is warm as well as the but the palms and soles are cold. It is considered to be hypothermia when the abdomen and the palms and soles are cold. This is the thermistor and is a servo control based. Assessment is done by digital thermometer or a thermistor probe which is placed on the right hypochondrium. Then by touching we can come to know about the temperature. Radiant warmer and incubation, they are used for hypothermia. Now, what's the difference between the radiant warmer and incubator? So this is the radiant warmer. It's an open care system, while incubator is a closed care system. Radiant warmer, it provides heat by radiation. Then in incubation, handling of the baby is difficult. Here it is a more of a restricted system, but however, the option to add humidification is present in case of incubators. About 80% humidification can be maintained in case of incubators, while in the radiant warmers, the insensible water losses or insensible heat loss from the body is more through evaporation. The maintenance and disinfection is easy in case of radiant warmers, and the maintenance cost is also low. In case of incubators, the maintenance cost handling is very difficult and maintenance cost is high. And the clinical features of early hypothermia will be pallor, cyanosis, and cool extremities, while in late hypothermia it is bradycardia, lethargy, apneic smells, poor feeding, high pitched cry, hypoglycemia, acidosis, then DIC, hypoxia, all these things. The prevention is done by maintaining the ambient to daily room temperature about 25 to 28 degrees Celsius. The ICU temperature to be 22 to 26 degrees Celsius. It should be free from drops. Skin to skin contact should be allowed. Then early initiation of breastfeeding. Postpone the bathing. Roaming in of the child with the mother. Co-bedding. Transportation is the weakest link wherein highest chances of hypothermia are present. In case of preterm infant, wrap the preterm infant in a polythene bag or a food grade bag, or incubators if they are available, because they lead to less insensitive heat loss from the body through evaporation. Also, humidification option is available. Then if it's just a case of cold stress, it is 36 to 36.5 degrees Celsius, then warm blankets can be used. Then skin to skin contact and breastfeeding is promoted. If it's a moderate hypothermia, then radiant warmer. If it's a severe hypothermia, then rapid rewarming should be done up to 32 degrees Celsius. IV dextrose, oxygen therapy, and injection vitamin K for other manifestations. Kangaroo mother care, it is given in case of low birth weight babies. It can be done in all babies except in sick. At least 1 hour session should be done, and it is stopped when the child gains a weight of more than 2.5 kg and the gestational age is more than 37 weeks. The mode of heat transfer is by conduction. Now, hypothermia also presents with tachypnea, tachycardia, and the management for this is simply undressing the baby and tepid sponging is done. A very important topic, that is breastfeeding. Breast milk is the ideal and natural food for the neonates, and exclusive breastfeeding it should be done for the first 6 months. It is important for the normal growth and development of the newborn. It has the potential to reduce the under 5 mortality rate by 13%, and so thus it is considered to be a single most effective intervention. It should be started within 1 hour after the birth. It decreases the chances of pneumonia as well as diarrhea in a baby. Now, the types of the breast milk. Types based on the stage of lactation. The first is the colostrum. So colostrum is found in the first 3 to 4 days after delivery. It is small in quantity. It is yellow in color, rich in antibodies, immunoglobulin A. Then consists vitamins of fat soluble vitamins like A, D, E, and K, and it acts as the first immunization for the child. Then the next is transitional milk. Transitional milk starts after the colostrum, that is 3 to 4 days up to 2 weeks, and it consists of the immunoglobulins, and the proteins are high, but the content starts to decrease while the fat and sugar content starts to rise. Next is the mature milk. Mature milk is found after 2 weeks. It is thinner and watery, but it contains all the essential nutrients for optimal growth. Now, in case of preterm delivery, there is a preterm milk. This preterm milk is seen in mothers delivering before 37 weeks. Now, this particular milk, it has got a more amount of sodium, the immunoglobulins, iron, protein, and calories inside it. Now, types on the basis of a single feed. So there are foremilk and there is a hindmilk. So foremilk, which is at the start of the feed, and hindmilk, which is at the end of the feed. So at the start of the feed, it is going to be water rich in proteins, vitamins, minerals. It is used to quench the thirst of the baby, while the hind milk is the one which is rich in fat, has more energy, and gives a feeling of satiety to the baby. So this hind milk is quenches the hunger of the baby. The baby must empty one breast completely to receive both the foremilk and hindmilk. Now, prelacteal feeds. If any prelacteal feeds are given, then these prelacteal feeds they increase the risk of clostridial sepsis. Now, immunological factors which are present in the breast milk that makes it superior to other milk. So, it consists of immunoglobulins IgA, which coat the infant's intestinal mucosa, and because of which the chances of dying due to diarrhea they are 14 times less likely, while the chances of dying due to pneumonia or any respiratory infections it is 4 times less likely. Then it consists of macrophages, lymphocytes. Then the proteins that consist of various defensive proteins like lactoferrin. Lactoferrin is the one which binds to iron and makes it unavailable to iron-dependent bacteria, and because of which the infections, because of Giardia lamblia, Plasmodium falciparum, and Toxoplasma gondii, they decrease. Then the lysozymes they act against the Entamoeba coli or Entamoeba histolytica. Then the bifidus factor is the one that promotes the growth of lactobacillus, and because of which the environment inside the intestine becomes acidic and all the bacterial growth is inhibited. So this is effective against Shigella, Salmonella, and E. coli, those bacteria which are very commonly implicated in diarrhea or dysentery. Then paraaminobenzoic acid is it protects against the malaria, and glycoconjugates they protect against the Vibrio cholera. So these are the different immunological factors. Then talking about the advantages of the breastfeeding. So it has got a nutritional superiority that we'll see further, where it has more amount of lactose, and similarly docosahexaenoic acid, which is responsible for brain activity. It provides ideal hydration to the baby because the water content is 88%. It protects against the different illnesses and is required for the brain growth or the mental growth of the baby. Now, the advantages for the mother is that it helps in postpartum recovery, helps in natural contraception because the 6 months of lactational amenorrhea is maintained because of breastfeeding. Then it helps in long-term health and convenience. It reduces the risk of breast and ovarian cancer. Contraindications to breastfeeding. There are some absolute and relative contraindications to the breastfeeding. It depends upon developed and developing countries. Now, in both, some absolute contraindications include the galactosemia. It's a rare metabolic disorder where the child is not able to metabolize the galactose. Similarly, the mother is on certain medications like chemotherapy, that is antineoplastic agents, if she is taking methyl dopa, or if it's amphetamines, or any other drug abuse like cocaine. So in that particular case, it is contraindicated. In cases of maternal illnesses, that is active tuberculosis or HIV infections, these are relative contraindications. So these are contraindicated in case of developed countries, but however in developing countries, the benefits of breast milk they outnumber the risk. So in that particular case, in developing countries where the replacement feed is not readily acceptable, feasible, affordable, or sustainable and safe, in those countries it is indicated to give breastfeeding. Then the techniques of breastfeeding. So correct positioning of the mother and baby should be present. Mother can either lie down or sit. The baby's head, body, it should be in a straight line, that is the occiput, shoulder blades, and the buttocks they should be in a straight line. The baby's body should be turned towards the mother, that is tummy to tummy position. Baby's whole body should be supported and not just the naked shoulders. Baby's nose should be at the level of nipples. Now this helps in good attachment. So what do we mean by good attachment? Good attachment means when the baby's mouth is wide open, when the most of areola is inside the baby's mouth, baby chin touches the breast and the lower lip is everted. Effective suckling. So it's a tendency of the baby to take slow deep sucks and then pause to swallow. So suck, suck, suck and swallow. Gulping sounds can be heard and the baby's cheeks they remain full and not hollow. That means it's a sign of effective suckling. Now, the different positions of breastfeeding are: there is a lying position or slide lying position. This is generally done during nighttime feeds or those mothers who are recovering from episiotomy or C-section. Then sitting position or cradle position. This is a traditional position which is most commonly deployed. Then cross cradle position generally done for twin pregnancies or in case of not in twin pregnancy, it is done in case of preterm or small babies. Football hold position or clutch hold position is done in twin pregnancies or where the mother's breast is large or it has got flat nipples. Then there are certain problems which are seen during the breastfeeding. So the first and the most common is the sore nipple. So sore nipple is caused because of incorrect attachment, and the management for this is proper training to the mother about breastfeeding, and avoid pulling the baby off the breast while still suckling. Then the breast engorgement. Breast engorgement is seen when delayed breastfeeding or infrequent feeding is present, and because of which the milk starts to accumulate within the alveoli. Management is advised for frequent breastfeeding. Apart from that, warm water packs, best massage and manual expression are indicated. Another thing is inverted nipples or flat nipples. In that case, manual everting of the nipples, rolling out of nipples is required. Use of plastic syringe can be done. Then, if there is not enough milk, then this is not enough milk is actually a psychological concept where it's a mother's perception. So in that particular case, you have to examine whether you have to assess whether the urine of the baby is passed about 6 to 8 times a day, or if the baby sleeps for 2 to 3 hours out of feeds, then that means the amount of the breast milk is adequate, and reassure the mother to have night feeds, so that it decreases the levels of dopamine and it increases the prolactin levels. Avoid supplements and bottle feeding. Then the breast abscess. Breast abscess is when untreated engorgement leads to cracked nipple or mastitis. It is because of a staph aureus infection. Mothers have a high-grade fever, and because of which analgesics, antibiotics should be given. Sometimes incision is required, and breastfeeding it must be continued even in this case. Then talking about the breastfeed, as I said, it leads to 20% fall in the neonatal death, 30% fall in case of under 5 mortality. Now, the maximum output it is delivered during 5 to 6 months, and the maximum output is about 730 ml, while the normal output is around 600 ml. The breast milk can be stored at different temperatures by expressing it. So at a room temperature 25 degrees Celsius, it can be stored for 6 to 8 hours. At a refrigerated temperature 2 to 8 degrees Celsius, it can be stored for 24 hours, and at deep freezers at minus 20 degrees Celsius, it can be stored at 3 months. Then express breast milk can be done, or human milk banks are present in India. It is there in Mumbai, that is called as Sneha. Then fresh milk is always better than donor human milk is better than formula milk. Now the composition of the breast milk is important. 100 ml of the breast milk, it has about 67 kilocalories. So the breast milk, it is rich in lactose, more than 7 grams per dl. The galactose, it consists of galactosaccharide, which is important for myelination, helps in carbohydrate absorption, and helps in the lactobacillus growth. Then the fats, there are about 3 to 4% of the fats, and it has got 30 times the level of docosahexaenoic acid as compared to a cow milk. Then proteins are less than 1 grams per dl, but those proteins have a high bioavailability and are good for kidneys. That is the whey proteins, lactalbumin or lactoglobulin is present. Amino acids that are present are methionine, taurine, and choline inside it, cysteine. Then the minerals, the calcium phosphate ratio is such that it helps in calcium absorption. Iron levels are low, but bioavailability is good. Then talking about the vitamins, it is deficient in vitamins K, B, and D. So vitamin D is required 400 international units, and vitamin K is given during the birth only 1 milligram intramuscularly. The water content, as we have discussed, is 88%. Now talking about the next concept, it is called as weaning. So weaning is also called as the complementary feeding. So complementary feeding should be started after 6 months, or it should begin at 6 months of age. It should not start too late, because that can lead to malnutrition. It should not start too early, because there are increased chances of infection. Then the foods that you should introduce. So in the complementary feeding, semi-solid energy dense foods are given. For example, mashed khichdi, mashed vegetables, porridge should be given. Then the frequency and progression. So begin about 2 to 3 times per day at 6 months. Then by 9 months, increase it to 3 to 4 times. And the quality and the quantity of the food and the variety of the food, it should be increased progressively. Now the principles of safe feeding. The principles of safe feeding are continue the breastfeeding even when the complementary foods are given. So the food should be prepared and fed in clean, hygienic manner, and do not force feed the child. Only feed when the child demands it. So this helps from overfeeding or force feeding. So this is all about breastfeeding. An important topic, that is neonatal resuscitation protocol. So when I talk about neonatal resuscitation, it's a systemic series of actions which are aimed at establishing effective breathing and circulation in a newborn who fails to initiate or sustain the adequate respiration at birth. The pathophysiology of the asphyxia. So the pathophysiology of the asphyxia is a primary apnea and a secondary apnea. So in primary apnea, there is an initial rapid breathing, it ceases and the heart rate begins to fall. The tone decreases and blood pressure, however, remains normal. So in case of primary apnea, the tactile stimulation done during this period, it may reinitiate the respiration. Secondary apnea, where there is a deep gasping respirations they occur. Heart rate and the blood pressure continue to fall and the infant becomes flaccid. An apneic newborn at birth should be assumed to be in the secondary apnea. Positive pressure ventilation should be started immediately within, and there is only 1 minute to decide this. This is called as the golden minute. The preparation for the resuscitation, first you have to assess the risk factors whether by ANC counseling, whether it's a high risk pregnancy or what is the gestational age of the child and amniotic fluid status. Then ensure the enough personnel, at least one person should be capable for the resuscitation and check whether all the equipments are present. Then the important components are TABC, that is temperature, provide warmth. Then airway, breathing and circulation are important. Now the resuscitation algorithm. So resuscitation algorithm, first the three questions are asked, that is whether it's a term gestation or preterm, then is the child breathing or crying, and good muscle tone. If these all three factors are present, then the routine care is given, that is provide warmth to the baby, dry the baby, clear the airway if needed, and ongoing evaluation. If no to any of these three questions, then in that case the first or the initial steps is warmth. The place the baby under the radiant warmer or wrap the baby in a cloth. Then the proper position, that is called as the sniffing position, where slight neck extension is done. Clear the airway. The airway should be cleared from mouth to nose and not from nose to mouth. Meconium stained liquor if the baby is vigorous and initial steps, provide the initial steps and observe. But however, if it's non-vigorous, then provide positive pressure ventilation. Then we have to dry the baby and stimulate. Tactile stimulation from the back or flickering of the toes should be done. So the way in which it is done is called as DSPS. So that is called as drying. Then that is drying, stimulation, then the pressure and the suction. Then the next step is evaluation. So we have to evaluate the heart rate of the patient. If the heart rate of the patient is less than 100, then in that particular case we have to start for a positive pressure ventilation. So positive pressure ventilation should be started within 1 minute. For the positive pressure ventilation, either we can use two methods, either a non-invasive or invasive. So first, the non-invasive ventilation, it is done by self-inflating bag or what we call as the bag and mask ventilation. The ambu bag that is used has a capacity of 250 to 750 ml. It should be appropriate sized face mask should be used along with that. Oxygen for the term babies, room air 21% oxygen can be given. For preterm babies, FiO2 should be about 30%. Then the rate, it should be 40 to 60 breaths per minute. So we have to give breathe 2 3 breathe 2 3 in that particular sequence. Then the pressure, for the first breath the pressure should be 30 to 40 centimeters of water, and in the subsequent breaths it should be half, that is 15 to 20 centimeters of water. And reevaluate the heart rate after 30 seconds of positive pressure ventilation. Then some corrective steps can be done, that is called as the MR SOPAR criteria. So instead for the mass reposition by proper E and C criteria should be used. Then the head repositioning should be done. Then suctioning of the secretion from mouth to nose, open mouth, increase pressure, and AR stands for alternative method should be tried. That is considering an invasive method, that is endotracheal intubation. So endotracheal tube 2.5 mm to 3.5 mm diameter is used, and this is used for ventilation. Now if by using an endotracheal tube, then start, if the heart rate falls to less than 60, then start with chest compressions. So the chest compression consists of two thumb techniques. So two thumbs, they are used to depress the lower 1/3 of the sternum just above the xiphoid process. The depth should be 1/3 of the anterior-posterior chest diameter, and the ratio is 3:1, 3 compressions to 1 ventilation. So it should be done in the similar fashion, that is breathe 1 2 breathe 1 2. So breathe, you have to do a compression as well as give a breathe, and then in the 1 2 you have to follow only compressions. Then reevaluate the heart rate after 30 seconds. If the heart rate goes to more than 60, then continue with it till the heart rate goes to more than 100, and then keep the baby only on ventilation. But if the heart rate is not improving, then we can go for medications, that is epinephrine or adrenaline in the ratio 1:10,000 is used, and it is given 0.2 ml per kg in the ratio of 1 is to 10,000 through umbilical venous catheterization or intraosseously or through the endotracheal tube. Then normal saline or ringal lactate solution is given when acute bleeding with hypovolemia is present in a child, and the dose is given as 10 ml per kg. And the post-resuscitation care is where to maintain the temperature stability, the respiratory status should be checked, blood glucose levels monitoring should be done, neurological status and fluid and electrolyte balance. The very important is the resuscitation protocol should be for only 20 minutes. If for 20 minutes the respiratory rate is not improving, then there is no use of further resuscitation, because also there is no use of further resuscitation if there is trisomy 13-18 or if there is going to be anencephaly in the child. Now this is going to be a proper flow chart of how this should be done: antenatal counseling, team briefing and equipment check. If the term gestation good tone, breathing or crying, then you have to do a routine care of the newborn. Then if it is any of these factors is no, then you have to go for TSPS, that is drying, stimulation, then positioning of the airway and suctioning of the secretions. Then next, if the heart rate is less than 100, positive pressure ventilation, first by non-invasive method, then MR super criteria for repositioning of the airway. If not, then go for invasive method, that is endotracheal tube intubation or laryngeal mask. If still the heart rate goes below 60 per minute, then go for the cardiac compressions in the ratio of 3:1. If still it is not improving, then consider emergency umbilical venous catheterization, or through the endotracheal tube you can give adrenaline, and it should be done for at least 20 minutes. Then the complications can be hypovolemia and pneumothorax. So in case of hypovolemia, we also give normal saline or recollected solution. Targeted SpO2 after 1 minute is about 60 to 65%, 2 minutes it is 65 to 70, 3 minutes 70 to 75, 4 minutes 80 to 85, and then 85 to 95 at the end of 10 minutes. So this is all about NRP. The next topic is respiratory distress. So there are various causes of respiratory distress. The first is the respiratory distress syndrome. It's the most common cause of respiratory distress in case of preterm neonates. It is typically found in the first 6 hours of life. Otherwise, there is a meconium aspiration syndrome, which is found in the first few hours of life. It is most common in postpartum infants or small for gestational age babies, and there is always a history of meconium stained liquor. Apart from that, neonatal pulmonary alveolar proteinosis, here there is a history of the siblings that is found in this condition. Pneumonia, it is seen in any age, and it is often bacterial and may be part of neonatal sepsis. The transient newborn, it is found in the first 6 hours of the birth. This is found in this is the most common cause of respiratory distress in term babies and after delivery of C-section. So there is a difficulty in clearance or delayed clearance of the lung fluids, and it is also called as the wet lung syndrome. Pneumothorax is a sudden deterioration in the SpO2 levels, and usually it is associated with meconium aspiration syndrome. Then tracheoesophageal fistula is a congenital anomaly that can also lead to respiratory distress. Then there is CPD, that is BPD, that is bronchopulmonary dysplasia or chronic lung disease, that can also lead to respiratory distress. Then diaphragmatic hernia at any age, where there's scaphoid abdomen, bowel loops in the chest on X-ray, that also leads to respiratory distress. Some other non-pulmonary causes that include congestive heart failure, congenital heart diseases, hypothermia, metabolic acidosis, and in central nervous system causes both asphyxia, intraventricular hemorrhage. So these are all the other causes that can lead to respiratory distress. Out of which the most important is the respiratory distress syndrome. Respiratory distress syndrome, also called as the HMD, that is Hailey membrane disease, is a problem in the preterm neonates. This is caused because of surfactant deficiencies. Now surfactant, it consists of the composition of the surfactant. It consists of the diapalmitoyl, phosphatidylcholine or the lecithin, and other surfactant proteins, that is A, B, C, D. Now this surfactant production starts at 20 weeks of gestation. It completes, or it is found in the amniotic fluid at 28 weeks of gestation, and at 34 weeks of gestation it is mature. So generally the respiratory distress that happens in preterm newborns who are born less than 34 weeks of gestation, the risk factors are, as I said, prematurity less than 34 weeks is the most important. Perinatal asphyxia, maternal diabetes, C-section without labor, acidosis, it is more commonly seen in male gender. The protective factors are antenatal corticosteroids and chronic intrauterine stress, for example, pregnancy-induced hypertension and all. Now, what is the pathogenesis? So pathogenesis is the surfactant deficiency. because of which the type 2 pneumocytes that produce the surfactant uh, which will not be matured if the baby will be born less than 34 weeks. Then the function of the surfactant is that it reduces the surface tension, and when there is a lack of the surfactant, then the surface tension increases, and because of which there is alveolar collapse or atelectasis. Poor lung compliance is seen that will lead to hypoventilation and hypoxia. The consequences of this hypoxia will lead to acidosis, it will lead to pulmonary vasoconstriction, increased pulmonary vascular resistance, and even more hypoxia. So that forms a vicious cycle. In hyaline membrane deposition, the ischemic change to the alveoli will lead to translation of the proteins, and these proteins will form a hyaline membranes. Clinical features generally found within 4-6 hours of life. The signs of respiratory distress are presented as tachypnea more than 60 per minute, intercostal or subcostal retractions, then alar retractions, grunting, nasal flurry. On auscultation, there is decreased air entry bilaterally. Initially, there is a gasping for air that is also seen. Then, on the basis of severity, there is mild, moderate, severe. So there are chest X-ray findings. So in the mild, the chest X-ray findings are bilateral reticulonodular reticulogranular opacity is seen. And in moderate, there is air bronchograms, that is the air is present in between the bronchos, so air bronchogram is seen. And in severe, there is a complete whiteout of the lungs, that is complete opacifications, as well as the cardiac silhouette, that is the heart borders, they cannot be traced out. The differential diagnosis is transient tachypnea of newborn, congenital pneumonia, or meconium aspiration syndrome. Management supportive care is given. Maintain the euthermia in the patient. Maintain oxygen by CPAP, and prevent the hypoxemia as well as hyperoxia, because there is a risk of retinopathy of prematurity. Then fluids and nutrition should be maintained by giving IV 10% dextrose, and acid-base balance by correcting the metabolic acidosis. The respiratory support in mild to moderate respiratory distress is given by CPAP, it is continuous positive airway pressure. It provides a continuous airway pressure of 5 to 7 centimeters of water to keep the alveoli distended or open. If it is not working, mechanical ventilation to minimize the volume of trauma or pyrotrauma. The specific therapy that is provided is the surfactant replacement therapy. So in the surfactant replacement therapy, the artificial surfactants like Baractant or Lucinactant are given. It is given via endotracheal tube, and the benefits are it increases the oxygenation and prevents the atelectasis or collapse of the alveoli. Indication, it should be given to preterm labor, suspected preterm labor, or premature rupture of membrane patients 24 to 34 weeks. Then the regimen, it includes the dexamethasone 6 milligram IM every 12 hours, 4 doses. Betamethasone 2 doses, 12 milligram intramuscularly at 24-hour interval can be taken. Then the benefits is not only has a benefit, it reduces the incidence of respiratory distress syndrome, but it also reduces the incidence of intraventricular hemorrhage, necrotizing enterocolitis, and neonatal mortality. Then the maximum benefit is seen 24 hours after the last dose and up to 7 days. Contraindications are frank chorioamnionitis, that is maternal high-grade fever, foul smelling like tachycardia in the fetus, and tenderness. Complications of RDS. It can lead to air leak syndromes like the pneumothorax, pneumomediastinum, intraventricular hemorrhage, patent ductus arteriosus, BPD, bronchopulmonary dysplasia, and retinopathy of prematurity. The next topic is low birth weight babies. So low birth weight babies is defined as the baby who is weighing less than 2.5 kg at birth. It either results from two important conditions: either a preterm birth, that is a baby born less than 37 weeks of gestation, or either because of IUGR, that is intrauterine growth restriction. The further classification can be very low birth weight babies less than 1.5 kg or extremely low birth weight babies less than 1 kg. Causes are the causes for the preterm birth can be preterm labor, then premature rupture of the membranes, or it can be because of multiple gestation, maternal infections like urinary tract infection or chorioamnionitis, and uterine or cervical abnormalities. Causes for intrauterine growth restriction are either symmetric IUGR or asymmetric IUGR. In symmetric IUGR, it is generally seen during the first trimester, where there is symmetrically the head to whole body is going to be equally reduced in size. This is generally found because of fetal causes like chromosomal abnormalities or due to torsion infection. Then in the asymmetrical IGR, this is caused because of maternal causes. This is found in second and third trimester. It has relatively good prognosis here because the brain sparring effect happens, and because of which the brain is normal while the rest of the body is found to be malnourished. Then it is caused because of placental insufficiency leading to pregnancy-induced hypertension or maternal diseases like renal disease, anemia, and all. This is calculated by Ponderel index. If the Ponderel index is less than 2, then asymmetrical IGR. If it is more than 2, then it is a case of symmetrical IGR. Clinical features of low growth babies are, so it's a case of preterm baby. Then it appears small with relatively large head, thin skin, visible veins, and minimal subcutaneous fat, sparse hair, and weak cry. In case of IGR baby, it has got a thin, slender look with loose folds of wrinkled skin, like moon-like faces is seen or monkey-like faces is seen, and the head appears disproportionately large as compared to the wasted body. And common problems that are seen are, so respiratory distress syndrome, apnea of prematurity, pulmonary hemorrhage. Right, in case of IGR baby, meconium aspiration is more. Then hypothermia is common to both. In the metabolic abnormalities, it leads to hypoglycemia, hypocalcemia, metabolic acidosis. Then the feeding, it leads to feed intolerance, necrotic enterocolitis. Hematological, it leads to apnea, prematurity, hyperbilirubinemia, polycythemia in case of IUGR babies. Then increased chances of infection, pneumonia, sepsis, and intraventricular hemorrhage, ventricular leukomalacia, hypoxemic ischemic encephalopathy. So the complications of low birth weight babies are, they have complication to go into hypothermia, hypoglycemia, respiratory distress syndrome, necrotizing enterocolitis, infections, jaundice, retinopathy of prematurity. It is seen in preterm infants less than 32 weeks or less than 1.5 kg in weight, that is very low birth weight babies, and intraventricular hemorrhage. This is caused because of the newly formed blood vessels. They are not strong enough. Then the long-term complications. The long-term complications will be growth failure, neurodevelopmental delay, visual impairment, hearing loss, chronic lung disease, and metabolic syndrome. So the management of this is anticipation, obviously, because if there is a spontaneous preterm delivery or premature rupture of nipples, it will lead to a low birth rate baby. Then spontaneous anticipation for IUGR. And similarly, gentle resuscitation should be done. Euthermia should be maintained by visual drying, skin-to-skin contact, and use of radiant warmer. Maintain the room temperature at more than 25 degrees Celsius. Then warm chain can be established, as well as kangaroo mother care, promoting the skin-to-skin contact as a standard of care for low birth weight babies. Then feeding. Now feeding, it depends upon the birth weight. If the birth weight is more than 1.8 kg, then direct breastfeeding can be done. If the birth weight is 1.5 to 1.8 kg, then spoon or paladai feeding should be done, because the suck swallow coordination has not developed. If the birth weight is less than 1500 grams or 1.5 kg, in that case we do a nasogastric tube based feeding, where the express breast milk is given via the orogastric or nasogastric tube. Then the choice of milk, exclusively breast feeding is the best. For very low birth weight babies, human milk fortifier is required. Feeding volume, it depends upon term and preterm. So actually in term babies, we start on 60 to 80 ml per kg per day on day 1, but as a low birth weight baby, they are preterm in nature, so we have to start at 80 to 100 ml per kg per day for day 1, and then increase 10 to 20 ml per kg per day. By the end of first week, it is about 150 to 160 ml per kg. Feeding frequency should be every 2 to 3 hours. Then monitoring daily weight, then weekly length and head circumference is important. In term babies, there is almost 10% weight loss by the end of first week, but here it is important in preterm or low birth weight babies, the weight loss is about 15% by the end of first week or 10 days, and it regains after some 15 days. Then therefore the gain of weight is 15 to 20 gram per kg per day. And the vitals like temperature, heart rate, respiratory rate should be monitored. Blood glucose monitoring is required at daily interval of 2, 6, 12, 24, and 48 and 72 hours. There's infection for the sepsis screening should be done. Then nutrient supplementation, because the breastfeeding, it lacks the vitamin K, B, and D. So the vitamin K in these high risk babies, it is given at 1 to 5 milligram intramuscular injection at a time of birth. Vitamin D 400 international units per day is necessary. Then iron 2 to 3 milligrams per day, start at 2 months of age. Then multivitamins as per the preparation, and calcium as phosphorus is given by the HMF, that is human milk fortifier. Then screening for different complications, that is neurodevelopmental complications, hearing complications, we can have BERA, and retinopathy of prematurity. It should be done in all the infants less than 32 weeks or less than 1500 grams, that is 1.5 kg. They should go at around 4 weeks of the postnatal age. But if the infant is less than 28 weeks or less than 1 kg, then the screening should be done within 2 weeks of the postnatal age. So the discharge criteria for the low birth weight babies, there should be thermal stability, that is, they should be properly clothed. The body temperature should be maintained well above 36.5 degrees Celsius. The feeding adequacy should be present, they should be fed well and gaining weight consistently more than 15 to 20 grams per kg per day for several days. Then maturity has reached a gestation of 37 weeks and a weight of more than 2 kg should be met. And mother's competence, that is, the mother should be feeling confident and trained in feeding during the discharge. There should not be any illness, and the follow-up plan should be present, and the parental counseling is important. So when all these things is done, these are the criteria for discharge. The danger signs should be consulted to the parents. They are the difficulty in feeding, where there is a persistent vomiting, lethargy, hypothermia, fast breathing more than 60 per minute, or chest indrawing, convulsions, and yellowish discoloration of palms and swells. So taking care of this, the low birth weight baby is monitored.